In this video, I will demonstrate how to create basilic vein transposition fistula using the last generation LigaSure device. We start with a brief presentation of the patient when he was 69 years old with diabetes mellitus, hypertension, and end-stage renal failure. We start on hemodialysis at 2016 via permcath. In January 2017, he came to us for vascular access creation, but unfortunately, he developed acute coronary syndrome. In February, we scheduled him for left brachial cephalic fistula creation. He did well with the fistula, with recurrent severe cephalic arch stenosis that required repeated angioplasty. Despite treatment with Enoxaparin, the fistula suffered recurrent multiple stenosis with thrombosis. Eventually, we lost the fistula in July 2022, nearly 6 years postoperative, and a new permcath was inserted. 1 month later, we scheduled him on August 22 for new right basilic vein transposition fistula. Planning new access is a major step prior to any access surgery using duplex scan. The occluded fistula in the left arm was not suitable for fistula creation. In the right arm, the brachial and axillary vein are suitable for basilic vein transposition together with the good arteries. Prior to surgery, a venography took place showing a nice patent vein for new fistula. Our patient now is 74 years old on hemodialysis via permcath. Recently, he had recurrent acute myocardial infarction with chronic chest pain. A right basilic vein transposition done at August 2022. Regional anesthesia is extremely important to improve outcome, along with microsurgical technique. In this case, we perform a supraclavicular, infraclavicular, and PEX2 blocks, which allow dilation of the vein in a painless surgery. We shave the area of surgery, scrub the arm with chlorhexidine soap, and then prep with 70% alcohol. The arm is covered with a sleeve, and the surgical area is covered with a bed sheet. We mark the surgical plan and start with a longitudinal skin incision along the distal basilic vein. With a diathermy, we dissect the tissue, and then we wide open the skin with a GLP device. We apply the LigaSure device for surgical dissection, delivering a unique combination of pressure and energy to create a consistent seal with each application. Reducing the number of suture ligation while reducing the time needed for the surgery is very important. Now that we ligate the branches, we can expose and dissect the basilic vein that will be transposed under the skin for easy access cannulation. We mark the vein with a purple skin marker, keeping the correct line of the vein. A vessel loop is used for vein elevation and dissection of the vein. We continue with the next incision and dissection. We continue with the fascinating LigaSure device, ligating and cutting tissue and branches that require for clear dissection. Then we mark the anterior side of the vein. We mark the anterior side of the vein. Keeping a clear area of the surgical dissection is extremely important for perfect surgery, and we close and burn every bleeding branch. we use a wet gauze over the incision, preventing the vein from drying out. We have reached the proximal incision in the armpit. We mark the skin, and then we dissect the skin with a surgical knife. Then we continue with the diathermy through the fat tissue. We continue with the diathermy, dissecting the tissue with a LigaSure device. We mark the vein with purple skin marker, keeping the correct line of the vein. Then we continue with the LigaSure. You can appreciate the nice quality of the basilic vein. We elevate the basilic vein with vessel loop. Then we continue with the LigaSure, avoiding damage to the nerves. We reach the junction of the basilic vein and the brachial vein in the armpit, and at this point we stopped, avoiding damage to the veins. At every incision, we use a wet gauze over the incision, preventing the vein from drying out. Now we move forward to the distal incision near the cubital fossa. We mark the transverse incision, and then we dissect the skin with a diathermy. By palpation, we feel the brachial artery and then expose it and elevate it with 2 vessel loops. We create a superficial tunnel with a 6 mm gore tunneler between the 2 transverse incisions. We cut the distal vein at the branches level with the LigaSure device. We pull out the vein all the way and lay it on a wet gauze. We cut the bifurcating branches and then flash the vein with saline solution, gently inflating the vein. We close the proximal vein in the armpit while inflating the vein. Then, with a soft grasper, we hold the edge of the vein and pull it through the gore tunneler and then remove it. We flush the vein and then close the proximal vein with the bulldog clamp. We shorten the vein for precise anastomosis. We use Galpi for good view of the anastomosis. We close the artery in both sides with a soft neonatal clamp, and a short longitudinal incision is created. We use a 7/0 Portland wire to wide open the artery, holding it with a delicate suture holder that make it easier for the anastomosis. We start suturing at the heel and continue with the distal medial artery line. Then we go back to the heel and suture the proximal lateral line, finalizing the anastomosis. We ligate the sutures and gently open the proximal artery to flush the artery blood. Then we close it and gently release the distal artery, preventing a possible junk flow to the forearm arteries. We remove the Portland holding suture and eventually we release the clamps, allowing a nice flow in the artery. You can appreciate a dilated nice vein. We use Surgicel for hemostasis and prevention of the infection. We then go to the axilla, releasing the tissues and fascia that compress on the vein, using LigaSure device, avoiding harm or impair the precious vein. We use surgical for hemostasis and prevention of infection. We close the axilla in 2 layers, brachial sutures and then nylon sutures. We continue with the rest of the incisions in the same fashion. For longitudinal incisions, we use absorbable stratific sutures with double needles, allowing 2 layers of sutures, deep and superficial. In our case, we suture both incisions in 2 layers. Eventually, we close the wounds near the anastomosis in 2 layers, brachial sutures and then nylon sutures. We apply hemostatic glue at the long sutures incisions with the stratifics, preventing bleeding from these incisions. We cover the wounds with a dermacombine ointment and then Cosmopore stickers. 2 weeks post-operative, you can appreciate the nice developed vascular excess that will start dialysis soon. 1 month later, the excess is ready for cannulation. The flow was 800 ml per minute and the vein diameter was 7 mm. We mark the cannulation sites and initiate dialysis. You can notice the developing swing zone stenosis. 3 weeks later, at 20 October 2022, we scheduled the patient for angioplasty due to severe swing zone stenosis, treated with covered stents, 9/60 mm, Covera flared stent with good result. 3 months later, at day 1, 2023, the fistula is still good, the access is doing well, and the flow rose to 1 liter per minute. At May 28, 2023, 4 months post-PTA, we noticed a posterior wall injury with flaps and vein stenosis that required angioplasty treatment. At 15 June 2023, the stenosis in the entrance to the proxy stent, treated with a 9.4 mm balloon angioplasty with good result. At 9/11/2023, we had a nice flow in the access without any significant stenosis. At 4 February 2024, the flow is 1200 ml per minute with mild stenosis in the entrance to the stent, yet there is no need for angioplasty. At 14 July 2024, the flow rises to 1300 ml per minute, the arteries are calcified, and there is a mild stenosis in the entrance to the stent, yet there is no need for angioplasty whatsoever. At 15 December 2024, the flow measured 1400 ml per minute with mild stenosis in the entrance to the stent, but there is no need for any angioplasty. We are still looking for the next examination within 6 months, but yet we did not have any problem in the access. Even after the stent inserted at the stenotic vein at 2022, we did not need any intervention over more than 2 years. Thank you for watching this video. In our center, we cover the creation, treatment and maintenance of vascular access creation, and you are welcome to watch and learn with us.